Hello, I'm Ruben Mesa. I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio MD Anderson, and joined here by my wonderful friend, colleague, and global MPN expert, Associate Professor of Leukemia at the MD Anderson Cancer Center, Naveen Pemmaraju. So, Naveen,
thank you, Ruben.
A lot of things going on at this ASH as it relates to MPNs, and I think a variety of things for us to discuss. But first, what are some of your takeaways from the hybrid experience? For those that have not had a chance to travel here, we know what a live meeting looks like. We know what now a bunch of virtual meetings have looked like over this time of the pandemic. Any takeaways from hybrid?
Well, Ruben, that's a great place to start because you and I have seen it all in these last 2 years. We've conducted virtual-only two-day conferences, and those work well for people who can't come or are not able to due to health or geography. This ASH is the first of its kind, a true hybrid event. We have sessions together that you and I have been in where the two moderators are remote, oftentimes in different countries. The presenter is remote on a pre-recorded video. Technical glitches that have followed as expected. But I think through the miracles of technology and medicine, we're all vaccinated, masking up, and patience, trying to have the patience with each other. We've been able to pull this off. I find it to be not only miraculous, but necessary. We've been able to get back into exchanging new ideas, new collaborations, new inspirations. Ruben, it turns out that just doing Zoom meetings for 2 years doesn't spark the intellect and inspiration as much.
It truly does not. No, from my end, I'm incredibly grateful. One, that we've been able to come here and be present. Truly the majority of on-site attendees, I would say, are from the U.S. at this point, just through the difficulties of travel, but it would have been not nearly as enriching an experience, and we clearly would not have had the depth of science without really all of our international colleagues, being here as well virtually. So I think we'll learn more, but I think over time we'll clearly get the sense that the moderators and presenters ideally present as much as possible. Right. I think is key. I think being able to absorb and interact with a meeting remotely, technology can well support. I don't think it supports necessarily the intersection of multiple remote presenters for a live audience. Right. That it falls short on. Well, why don't we start just a bit on the science side? Okay. So we had the plenary session today that I know I just saw your tweet just very recently that came out as it relates to the role of P53 potentially and why MPNs progress to AML. Maybe just share a word or two. What are some of the takeaways from that? Is that just biology at this point, or anything you think we can really do if I order NGS on someone next week and I see P53? Should I freak out?
Oh, this is great. I'm glad you started off on that. Yeah. This is something you and I have talked about for many years. It's really cool to see our MPN sessions highlighted at ASH. There's 5, maybe 6 oral presentations at ASH this year, including being on the plenary once again. The key concept that you just brought up is important. Chronic diseases don't stay chronic all the time, as you and Serge and many others have shown. So if you have an MPN, particularly myelofibrosis, the worry, the danger, the risk is that it can go to leukemia. We see it all the time in the clinic. The question here at ASH over the last 2 years is, can we predict it? Can we do something about it? And can we ward it off altogether? So this is kind of really nice work that builds on the work of our colleagues in New York, Drs. Ross Levine, Rajit Rampal, our colleagues and friends, where there's something called TP53, the guardian of the genome that gets hit, it gets lost, it gets messed up, and now these cancer cells start to proliferate. And in our MPN, unfortunately, that seems to be very important. It seems to herald the transformation to AML leukemia, and worse so, there may not be a whole lot we can do to directly prevent it at this time, except to understand that the combination of inflammation, so tissue injury, picking up mutation or mutations, and then some people will then go to AML leukemia. That was a big talk here at the plenary session, suggesting that single cell analysis in the lab can kind of predict what these cells are going to do before they show up clinically.
Very good. Well, very important progress, and exciting to see truly how many important discoveries from MPNs have really been, discussed at the plenary session at ASH. So just a sign of the depth of the kind of scientific focus, some of the great scientific firepower. That's from that wonderful Oxford Molecular Medicine Institute that has really had a tremendous history and impact over the years. So exciting.
It also, what you're talking about is important because it highlights the cross-continental collaborations we've all had, right? The UK groups, multiple groups in England and across the world, collaborating with our groups in Texas and New York and beyond. And what's really great, and you're really one of the pioneers of this, is taking discoveries in the MPNs and then putting it into all the clinical trials. For example, you pioneered the MPN symptom burden, the so-called TSS score. You must be gratified. I was going to say this to you anyway, but now we're on camera. I saw your work on every single clinical trial showing the decrease in the MPN symptom burden. What is that like 10, 15 years later after you came up with that?
Well, it's really grateful and gratifying to see. So one, clearly, many involved with that, amazing work by Amy Lou Dueck, our statistician, who was key with that, Robin Scherber and others, and clearly patients. But what's great as we walk this journey is at first, there were a lot of people who pushed back, including journal reviewers, that symptoms, aren't a big deal.
Right.
In fact, the first paper I had data on symptoms from 1,500 patients, and it was refused by a reviewer who had said, well, I have 3 patients and they don't have symptoms, so I guess the patients are lying.
Oh, wow.
So to see that evolution where now we have validated tools where it's really become the standard, both in trials, and in practice has been really gratifying.
Wow.
And I think it just gives us insight that, I think the really next level is what does it tell us about biology?
Yes.
Because I think there's a link to biology. There are undoubtedly, issues in terms of depression, anxiety, and others that can factor in, without question. We've done some of that work as well. But there's really a biology piece. Now, one of the areas that we saw that was very interesting is we pivot a bit toward therapies. Great thing at this ASH is that there's really some interesting updates in ET, PV, and MF. Before we get to MF, where it's always the lion's share, drugs are really kind of vetted in that most difficult group. In ET, I was very excited in seeing the report from Italy, a multi-center study. There's a parallel study at our institution at the Mesa Cancer Center with the LSD1 inhibitor IMG 7289.
Yes.
And ET has been somewhat of a difficult space. There's a lot of patients, maybe 150, 200,000 in the U.S. We have hydria. We have anagrelide, interferon off use, a little bit of ruxolitinib off label, but the bench is fairly thin.
Right.
So this is a nice study, and I would say that our experience and our ongoing study is similar in patients with hydroxyurea failure, really showing this different mechanism of action, the ability to both control the platelet count, improve symptoms, and potentially have a little bit of a deeper impact on the disease. So early going.
Right.
We also know, I presented a poster yesterday of our now accruing Phase III study, shamelessly plug it here in this video, the Surpass ET study, where your colleague, Serge Versavchik, and I are leading. Ropeginterferon, now approved in PV, compared to anagrelide for second-line therapy. So, new therapies upcoming in ET. Now in PV, we again see some potential new options, particularly these hepcidin mimetics. Why don't you share with folks a little bit of what that Rusfertide data looks like, but why hepcidin? Why would we want to give a hepcidin mimetic?
What an exciting conversation, because you really tied in nicely the elements of biology and in the lab, and then the patient-centered journey, which you and I have always been so focused on, again, with the symptom burden, spleen size reduction, and then moving the story into the earlier patient journeys, ET and PV. PV, all of a sudden now, an exciting time for our patients and caregivers, Ruben. Hasn't been necessarily the case over the last decade. The two developments that you mentioned, the ropeginterferon Bezrimi, now US FDA approved as of a week or two ago, really pioneered in Europe by our friends Jean-Jacques Kalajian and Dr. Gislinger. So I'm excited that new formulation of interferon, an injectable for our patients, is out. But the PTG 300, the Rusfertide Rusfertide. That's the new agent really being discussed here at ASH. So the principle is in Vera, too many red blood cells, too much iron imbalance, homeostasis is not right. And so now we've been phlebotomizing our patients, asking them to do the long blood draws. Nobody likes that.
Yeah.
The doctors don't like that, the patients don't like that, the family members don't like that. And it's a transient maneuver. So scientists, including some of our colleagues, said, what about something like a continuous phlebotomy state? Can you make that iron imbalance normal again? Can you tell iron and blood cells to not be so active and go back to their spaces that they belong to, whether it's the liver, the blood, or wherever? So this drug, Rusfertide PTG-300, tries to mimic that process through an agent called hepcidin, which tries to tell the iron system, hey, take it easy, have some balance here. Interestingly, it's also a once-a-week injectable, which is already common in our field anyway. That's interesting. And what we saw today in sort of back-to-back oral presentations in our session today is not only this agent works to decrease the phlebotomies or actually eliminate it in many of the patients, but that there's scientific correlative data to suggest it's actually doing what we thought. It is actually normalizing the iron levels. It is actually bringing down these ferritin and hepcidin balance levels. So I think the bottom line is that trial is in an ongoing phase 2. And then as with all of our trials, let's let that get into the phase 3, the larger setting, so we can see more data, see if this is something we can bring to patients one day.
So exciting updates in ET and PV and possibly some new therapies soon, but certainly ropeginterferon, for those that have not used interferons yet, I think will really have a really favorable impact.
Right.
You know, it has a fairly broad label. Now let's pivot a bit toward myelofibrosis. You know, the energy of drug development always really begins with myelofibrosis.
Right.
I think because it's, you know, the patients really can have a lot of burden of disease. It clearly has the greatest impact in terms of both morbidity and mortality. So let's first start with the drug that's approved, but many folks haven't yet quite had an experience with, which is Fedratinib. And we heard from Vikas Gupta today some updates from the FREEDOM study that I believe you guys are involved with as well.
Right.
That is, you know, looking at now kind of the experience kind of post-approval, you know, in a study setting, and both related to toxicities as well as the issue with thiamine.
Right.
So any takeaways from that might be reassuring for folks that have been kind of sitting on the sidelines waiting to write that first prescription for Fedratinib?
Yeah, for me it was very exciting to see that. This is Dr. Vikas Gupta, our friend and colleague in Toronto, Canada. Beautiful talk today on the so-called FREEDOM trial, Phase IIIb. So exactly as you said, Ruben, kind of all the drugs already approved and in our hands, but to the credit of the sponsor, you, Claire Harrison, all the investigators, let's keep looking at safety and tolerability. That was the focus of Dr. Gupta's talk. I was excited by it because he showed three things. One is we know about the GI toxicity signal already part and parcel with the drug. He gave some practical mitigation maneuvers. Hey, when you're prescribing this drug, a little bit of patient education, doctor education, some preemptive prescriptions for nausea, vomiting, etc. That was very helpful. Number two, the big story, which you, Claire Harrison, and others reevaluated, was that there was a signal for Wernicke's encephalopathy, a potentially serious, maybe even a fatal disorder involving vitamin B1 or thiamine deficiency. Your reanalysis showed that may not be so much of an issue, and this kind of helped us to understand that. Yes, you should check thiamine levels, you should replace them, but it's not going to stop us in prescribing this medication. I was very pleased to see that, and he showed those levels over time. And then a third part. This is only the second of two agents FDA-approved JAK inhibitors in our entire field. You helped to pioneer the first one, ruxolitinib. This is the second one. So now we know in longer follow-up, it's safe, it's effective, you can mitigate these fairly tolerable side effects, and you should be watching out for encephalopathy in general, not necessarily the Wernicke's, and it's something that we can do as a field. It's also important to note that it's not just another JAK inhibitor. Each of these and we have the pacritinib and momelotinib in phase 3 studies still, look at the other targets that each of these JAK inhibitors are hitting, and then you can use them in sequence depending on the JAK inhibitor. So it was a very exciting presentation.
Very true, very true. As folks ask me, at this meeting, how do I view the landscape for myelofibrosis? And obviously many things in development, many more than ever. So I try to break it into kind of different segments. One, the JAK inhibitor segment. We have 2 approved drugs. They're both good drugs. They're now we're celebrating more than 10 years that ruxolitinib has been approved.
Wow, right.
And the impact that it's had, we think of all the patients that have benefited over this decade, is tremendous. In last year's ASH, you guys presented a beautiful paper that really continued to validate the observation that there's probably a survival advantage for people who are treated on that. But now we have 2 that really are on the cusp of also probably being part of this equation as we think about optimizing JAK inhibition. The first is pacritinib, that we think, and it's in the public domain, that it hopefully will be available for patients to be commercially prescribed in Q1 of 2022. So where might pacritinib fit in for our MF patients?
A very important question. The issue with the 2 approved JAK inhibitors is that, at least in terms of package label and the way we all studied it, there's a platelet cutoff. Whatever it is, 50, let's say, for these 2. So below that, there's really not a JAK inhibitor there. So this agent, pacritinib, has been shown that it can still be given safely and feasibly even in patients with low platelets. So I think that's very exciting. And then the second aspect, as we were mentioning earlier, is that each of these JAK inhibitors hit different targets. In the case of the pacritinib agent, it hits IRAK and some of these other pathways, which are implicated in what we call the inflammasome or mitosome, and that may have other pleiotropic effects that are still being studied in the lab and in patient samples. So you and I, we see patients every week. We welcome this because each of these agents is not, quote, just another JAK inhibitor. It gives us another option. The other aspect of it is what about long-term safety and efficacy? Sometimes those things are observed after a drug is already approved, and that's something that you and I are comfortable with. Why the Rux has over a decade now of post-approval data. I think the other issue for us is combination therapies, right? And you and I have been part of that, and I wanted to get your take on that, which is combining agents with a JAK inhibitor. What has caught your eye there at this ASH, Ruben?
Well, I think there's a lot of exciting things. I think first, patients will probably be on an optimized JAK inhibitor. We add in the 4th JAK inhibitor, momelotinib, also working against ACVR1. It's inhibiting hepcidin, might help to improve anemia. And I think pacritinib and momelotinib really will factor into the treatment landscape in a range of ways, particularly in patients with thrombocythemia or anemia or both. Maybe some front line, clearly some second line as well. But the combinations are really interesting, and there's multiple. I could just to list a few: pelabresib, parsaclisib, navitoclax, selinexor, on and on. There's so many of these different drugs that we're looking at. The MDN2 inhibitor from Kartos, many of them. From my end, I think, one, these drugs may be able to improve the response rates of those things that we have historically valued. A higher degree of spleen or symptom response, either in the frontline setting, which is now being asked with navitoclax and pelabresib, but others may go to that kind of untreated group. In this kind of add-on group, if you're on for a while, you add these drugs on.
Yes.
What do you gain? And then third, in the kind of we failed Rux, now you're on this drug alone. Now all are starting to see different potential additional areas of benefit. Maybe improve cytopenias, maybe improve fibrosis, maybe improve allele burden. All I think need to be viewed with some degree of these are still really exploratory endpoints. We don't know quite what they are, but I'm excited.
Yeah.
I also take a bit of a bird's eye view and say what we have is we have a series of phase 2 studies with several ongoing phase 3 studies, but we truly only have phase 3 data in JAK inhibitors at this point. We have no phase 3 data yet in any non-JAK inhibitor.
Right.
So there is some amount of, we really do need to let these things play out.
Right.
See really what the final data is. Because people say, well, how are they going to factor in? I think it's going to depend.
Okay.
I think from my end, it's going to depend, what was that efficacy exactly? Are there really subgroups? Because we are talking about combination therapies likely will be quite expensive, and potentially have other toxicities. But how do you see this evolving? In any that if you were to say, boy, these are the ones that I'm most excited about at this moment, what would that be?
Yeah, I like the way you fleshed out and outlined this field because many of our colleagues have been used to just one drug or one class of drugs. Wow, you really nailed it. So the combinations can be in 3 ways now. Upfront, JAK inhibitor naive, suboptimal response add-on, and then completely relapse refractory. I really would pick up where you just mentioned, which is in these novel mechanisms of action. You have the bromodomain inhibitor, pelabresib, as you mentioned. So we have some single agent activity with that now being combined. So that mechanism, bromodomain, looks like it modulates MPN cytokines, megakaryocytes, erythrocytes. So maybe at the level of the bone marrow in our patients. That combination is very exciting, Ruben, because our colleagues have shown that there may be anemia improvement early on. These are ongoing studies. We want to let everyone know these are in clinical trials, so we want that data to mature, as you mentioned. The second one, as you know, I'm very much involved in the Ruxo plus navitoclax data that you and I are both a part of. That's BCL-XL. Here's what you were talking about, the fascinating miracles of drug discovery. Everyone out there knows the venetoclax story, BCL2, which is now approved in a number of different leukemia states, but BCL-XL is still not yet FDA approved. It's in active clinical trials. That appears to be active for some reason in our myelofibrosis, so that agent in combination with Ruxo is now in phase 3 studies and the Transform studies. We eagerly await those data. And then finally, as you mentioned, the PI3 kinase inhibitor story, parsaclisib, also in combination with Ruxo, also going into phase 3 studies. Those are in the frontline setting, but then you also have the imetelstat agent, which our colleagues, including John Mascarenas in New York, are developing. And the key there is phase 3 study, relapse refractory, but for the first time in our field, overall survival as the primary endpoint, which I know you and I are excited to see. Patient-centered focus. It's what we started out talking about. Biology, lab science, symptom burden, spleen. How about overall survival? What do you think about that in terms of these new breed of phase 3 trials?
I think it's key. I think, one, we'll really need to see the data. As people say, well, the initial response rate looks higher than the comfort studies. I always caution a word of caution with that. Meaning, having put people on those studies, the people that we put on an upfront study now are not the people that we put on the comfort study. The comfort study was, we had no prior effective therapy. So it was people that had had the disease for years, sometimes with advanced disease.
I see.
They'd failed hydroxyurea, they'd failed all sorts of things. They hadn't failed the JAK inhibitor, but they'd failed all sorts of things. That is different than the almost newly diagnosed patient. So I do think the control arms of some of these studies may do better than the comfort studies had done historically. So we'll just have to see. But I think it's all positive. If there's 10 drugs approved for myelofibrosis, that's fabulous.
We'll take it.
And people say, well, how can that small, disease really support all these drugs? I'm like, that not to worry. In part, we know that many of these therapies that really are quite innovative may impact a range of disease. They're developed in a bunch of things. It's not that they have to really only exist just based off myelofibrosis. But our patients are heterogeneous. We know that there's a lot of patients with unmet need in MP and MDS overlap syndromes, in more advancing disease, other combinations. So the more options we have, I think, the better off we are. It's not to say that we have a full dance card and and can't really develop it any further. So this has been a wonderful update, my friend. Maybe give folks kind of a final thought, exciting thing. What is your most exciting thing you're looking forward to as it relates to MPNs for 2022? For 2022, as the pandemic extends, you and I and others have talked about that. I've got 2 takeaway points for our folks out there. One is that despite difficult times that we've all faced internationally, here back home in the States, that we must, it's imperative, it's a necessity that we continue to meet like this at meetings, online, virtual, hybrid if it's safe,
because no matter what's going on in the world, we must continue our work in these rare blood cancers. Because Ruben, as you and I have said many times before, if you have a rare blood cancer like myelofibrosis, PVRET, it's not rare to you. That's what you and your family are dealing with. We must continue what we're doing, and I'm very proud that our field has moved on despite these last 2 years. The second takeaway is what you said there. I'm eager to see the mature data on the combination studies, to see how we deal with overlapping toxicities, low blood counts, dose adjustments of one or the other, and then if and when these get approved in the community setting, looking forward to a few years, how they are done off of clinical trials, right? And I think you and I will be helping to learn, teach, collaborate with people on that. So I think those are my two takeaways. What about for you, Ruben, as we close this?
No, wonderful. First, with this unprecedented number of phase 3s, I think the data from the phase 3s, the correlative studies, will be scrutinized to a tremendous detail. I don't think that it's just a matter of, we validated what we presented at ASH in our phase 2. I think the granularity, the details will be important because there will be multiple options, and how we use them and how we really tailor that to the care of an individual that may have a complex disease journey will be critical. The second that we've not yet seen, but really excites me, are the various strategies that are being planned, vaccine, CAR-T, immunologic, around CALR mutated disease. CALR expressed on the cell surface, it at least in theory seems one that we might be able to address in a slightly different way. Still kind of a proof of concept, but boy, wouldn't it be exciting if that really makes, a very complementary difference to some of the things that have already been developed.
That's great.
Well, great. Well, this has been a wonderful chance for us to chat on Vijay Hemag, reporting here from ASH of 2021. My friend Naveen, thank you for joining me.
Thank you, Ruben.